This is Donna Gress, and the topic of this webinar is blank versus X, definitions and data interpretation for AJCC staging. So first we're going to look at the definition of TX and NX. From the AJCC Chapter 1, Principles of Cancer Staging. There is a section discussing the unknown designation, which is X. This is for physicians to use when the information is unknown or cannot be assessed. It is for TX and for NX. There's also a section in Chapter 1 that talks about assigning stage, the role of the managing physician. This stage includes the T, the N, the M, and also the stage group. It is important to note that the pathologist and the radiologist, while they provide some very important staging information, they cannot stage the patient because they don't have access to all of the information as the managing physician does. So the definition of X. X is defined by AJCC as cannot be assessed. Only the managing physicians assess patients by exam, imaging, procedures, or surgery. The managing physician must be the one to assign X or describe that they do not have the information, which is the same as the X category. X must only be the managing physician perspective of the patient's story. If the X definition is not met, the only option for the registrar is to leave it blank. There are no other AJCC values available to assign if X 0, 1, 2, 3, or 4 are not correct. There is no choice left for the registrar except to not assign a category. If the registrar cannot assign a category, it is left blank, or in other words, skip over that data item. The registrar would not assign any other AJCC category if the definition wasn't met. Would a registrar assign T2 or N1 if that definition was not met? So we have to make sure that we don't change the rules for X. If the definition has not been met, it cannot be assigned. X is not the same as unknown to the registrar. Now the AJCC staging rules for X. Those rules only include criteria for X. That is because the Chapter 1 and the staging manual were written for physicians to use in patient care. There were no rules written for the registrar to use for blank because it seemed intuitive. If the registrar doesn't have the information from the physician, they have to leave it blank. If the word blank is confusing, think about you have to just skip that data item. If you don't have the information, you can't fill anything in, you just have to skip it. The managing physicians document information about the cancer in staging. They include TX or NX as appropriate based on that patient's care. Now, the pathologists no longer use X. The PT or the PN is not assigned by the pathologist if they cannot determine the information from the specimen they were given. And that is a decision that was made by both AJCC and the College of American Pathologists jointly. It is so important to tell the patient story through staging from the managing physician perspective. X means the managing physician has no exam, imaging, or procedure results, or those results cannot be quantified. Blank means the registrar had no access to the managing physician information, or no valid T or N category information was provided. Now, a little bit more about the physician use of X. The managing physician may use X. They are the ones that perform an assessment of the patients. They're responsible for the patient staging. As we saw in Chapter 1, the rules are clear. That is the responsibility of the managing physician. X is for the patient using all available information. Now, pathologists and radiologists may not use X. They do not assess the patient. They cannot assign staging for the patients. They can only provide helpful information to guide the managing physician. They have very limited information. They're looking at one imaging test or one specimen. So as I said earlier, X is for the patient. So a pathologist or radiologist cannot use X because it is for the patient, not just for that one imaging or the one specimen. AJCC and the College of American Pathologists agreed to no longer allow pathologists to use TX or NX. That decision was made in June of 2021 and was put in many of the different AJCC information vehicles, such as the Cancer Program's newsletter, on our website, and through other venues. The CAP protocols have been updated to include this, and if not all have been updated, they're in the process of doing that. The change was also made to the AJCC Chapter 1, and you will find that in the errata. The pathologists agreed with this. They realize they do not have access to all of the information, so it is not appropriate to use X. Because again, X means no one knows for that patient, not that you didn't know it for that one particular specimen that they have in front of them in pathology. Now, stage classification, blank or X. Does the patient meet the stage classification criteria? If yes, the patient meets the classification criteria. That means the managing physician could not assess T or N for that patient. Then the registrar may use TX or NX. So if the patient, let's say, was having clinical staging done and the physician did a diagnostic workup, so they met the classification criteria, and in that situation, the managing physician said he could not assess either the T or the N or both, then the registrar may use it. So even if the managing physician did not come out and say TX or NX, if the managing physician made it clear they could not assess, then the registrar may use it. And if yes, the patient meets that classification criteria, and there is no information in the chart, in the medical record, on either the diagnostic workup for clinical staging or the diagnostic workup, operative findings, or resection pathology information for pathological staging, registrars do not use X because that would imply the physician did not assess or have information on the patient's T or N. The registrars must use blank. Indicates the registrar could not find the information in the chart. So again, if the managing physician could not assess the patient, then TX or NX are valid, if they met that classification criteria, of course. And if they met that classification criteria, but the registrar could not find the information in the chart that they needed, the registrars in that case do not use X, they use blank, because the registrar could not find the information. Now, what if the question, does the patient meet the stage classification criteria? What if it's no? Patient does not meet that classification criteria. For example, it was an incidental finding at the time of surgical treatment, and so there's no clinical staging. In those cases, registrars do not use X. That would indicate the patient was eligible for that staging classification, clinical, pathological, post-neoadjuvant therapy staging. It implies the physician did not assess or have information on the patient's T or N. The registrar must use blanks because that indicates the patient did not meet that classification criteria. Another scenario, no, the patient does not meet the classification criteria. If there's no diagnostic workup, then there's no clinical staging. That is not CTX or CNX. They must be blank because there's no clinical staging. What if there's no surgical resection? Then there's no pathological staging. So that's not PTX or PNX. They must be left blank. What if there's no surgical resection after neoadjuvant therapy? Then there's no post-therapy pathological staging. It's not YPTX or YPNX. It must be blank. So when a patient does not meet the criteria for that staging classification, the registrar must leave those blank, skip over them, because using an X indicates the patient was eligible for that staging criteria and the physician was not able to assess the patient. Clinical and pathological staging. We tell the patient's story through staging. X means the managing physician has no assessment results or results cannot be quantified. So for clinical staging, it's the story of the patient's diagnostic workup. CTX means the managing physician has no exam, diagnostic workup results, or the results cannot be quantified. CNX means the managing physician has no exam, diagnostic workup results, or the results cannot be quantified. Pathological staging. It's the patient's story from diagnosis through surgical treatment. PTX would indicate the specimen cannot be evaluated. Maybe it was fragmented or destroyed somehow. And no clinical information or operative findings could quantify the T category that was needed. For PNX, that would mean no regional nodes were microscopically examined at any time from diagnosis through resection. So registrar blank usages. Blank is used by the registrar when there's no information available in the chart, the registrar has no access to physician information on the patient, they cannot be assigned a valid AJCC category according to the AJCC definitions and criteria. The valid AJCC categories include X, 0, 1, 2, 3, and 4, or any subcategories. The patient is not eligible for that stage classification. So CT blank means there was no workup for that patient, no diagnostic workup. It's an incidental finding at the time of surgical treatment. PT blank would mean patient didn't have surgical treatment. And YPT blank would mean the patient didn't have surgical treatment after neoadjuvant therapy. So it's important the information that we convey by leaving something blank if it's not appropriate. Now, clinical and pathological staging for the M category. X does not exist for the M category, so it must be left blank if the registrar had no access to managing physician information or no valid M category information provided. Now, for a CM0, that only requires a history and physical by the managing physician. And I've been asked this question more than once. It does not mean the registrar must find the H&P on the chart. I've had registrars say that they look through the chart and they don't have an H&P. But if you know a history and physical exam was done by the managing physician, then that meets the criteria. Because if the managing physician suspected metastatic disease, it would definitely be mentioned in the chart, and the treatment plan would be different. Now let's talk about the harm that can come from using TX or NX. Sometimes registrars get exasperated and it's like, what's the big difference between an X and a blank? Well, here are some examples, real life examples of the harm that could come. So here are some issues with registrars using X. These are actual examples of physician interpretation of registry data, uh, phone calls and emails that I've handled when physicians have questions about data files. Registry data should reflect the information in the medical record and the managing physician's care of the patient. These examples showcase the importance of the accurate use of X. We have to differentiate between the physician cannot assess, which is X, and the registrar doesn't know, doesn't have the information, which is blank. It illustrates how data is interpreted and that registry data could lead to false or erroneous conclusions based on the registrar use of X. So this is a case where the physician had a question. He was looking at breast cases in the NCDB PUF, the participant user files. The cases he was reviewing were CTX CM1. So the physician's concerns were that once the patient's distant metastases were identified and it was decided that they were compatible or consistent with coming from a breast cancer, that no breast exam or any type of breast imaging was being performed because CTX means that there was no exam or imaging assessment or the results could not be quantified. And he found that very confusing. How could someone do a breast exam and then mammograms and ultrasounds and maybe even a breast MRI and never be able to quantify the breast tumor? The physician was making plans on writing medical journal articles showing that the data showed that complete workup of breast cancer patients was not being performed by physicians. And he was trying to convince physicians that it was important for them to step up and assess these breast cancer patients appropriately by assessing the breast tissue. And the physician asked questions of AJCC to verify the findings that he was coming across in the National Cancer Database, which is data submitted by registrars. My explanation was it was more likely a registrar issue, that the registrar could not find the data in the chart, and so the registrar was inaccurately using CTX, because CTX indicates that no breast assessment by exam or imaging was being done, or the patient refused it, or the physician just never ordered it, or exam or imaging results cannot be quantified. But the physician explained that it was very rare and that it was really standard of care that even with metastatic disease, the breast should be examined by physical exam and by all these different, at least some of the different types of imaging techniques available. And it was really not appropriate care by these physicians, which is why he wanted to write the article and bring attention to this huge problem that he saw that was going on in the United States, that women were not being treated appropriately. Once he, convinced me that this was really standard of care, then that's why I came up with the explanation that it really had to be a registrar issue, because it was hard to imagine that that large of a percentage of physicians across this country were not treating breast cancer patients appropriately. So the issues: registrars did not have access to the information. That is not CTX. CTX may not represent what the physicians really knew about their patients. Some registrars were incorrectly using CTX if they couldn't find the information or they weren't able to ask the physicians for more information. And the registrar using X and not blank was skewing the data that the physician researchers were seeing. And the Registrar X could lead to incorrect conclusions on patient care being published in leading medical journals, which could be a real embarrassment to these physicians doing the research who trust registry data. And we want them to trust our data. Here's another example. A physician was looking at melanoma CNX cases in the NCDB PUF. The physician's concerns were the nodal area, clinical and physical exams or imaging was not being performed. The nodal area assessment is part of national workup guidelines, and it must be assessed for lymph nodes, satellites, and in-transit lesions. He was very concerned that physicians in this country were not following national guidelines for the care of melanoma patients. The physician was planning to write a medical journal article and do some lectures at big national meetings because he was convinced the data was showing that the complete workup for patients was not being performed, and really wanted to convince physicians that it's so important to assess the nodal area so that patients are being treated appropriately and don't have recurrences and bad outcomes. And so the physician was asking me a lot of questions to verify these findings in NCDB. And again, when he explained that this is standard of care and the high percentage of patients not receiving an appropriate standard of care, I had to explain that it was more likely a registrar issue. The registrar couldn't find the data in the medical record, and so they inaccurately assigned CNX because CNX indicates no nodal area assessment by exam or imaging, or the patient refused, or the physician just never ordered it, or the exam or imaging results can't be quantified. They couldn't figure out when they were looking at them what they really true answer was, whether it was CNX, CN0, CN1, etc. So again, the issues. Registrars did not have access to the information. That is not CNX. CNX may not represent truly what the physician knew about the patient. And remember, CNX should represent what the managing physician knows or doesn't know. Some registrars incorrectly use CNX if they can't find the information or they don't ask the physicians for more information. Registrars using X and not blank skews the data for physician researchers, and the registrar X could lead to incorrect conclusions on patient care being published or lectured at national meetings. Now, my third example was rectal cancer cases. They were CTX in NCDB, and the physician concerns were no appropriate imaging assessment was being done. And he said this was especially a problem since NAPRC, the accreditation program for rectal cancer, those guidelines are very clear about the appropriate workup for rectum. So the physician plans on working with NAPRC and the accredited centers because the data was showing the appropriate imaging was not being performed, convince these physicians that it's critically important to follow NAPRC guidelines, and also make sure and determine if the issue was truly with the physician care or if it was registrar staging, and then choose the next appropriate steps depending on the source of the problem. And this could affect the accreditation of some of these different centers based on the data that was being found. So again, the physician was asking AJCC and me for help in understanding these findings. Well, with all of this evidence, again, I had to say that it was more likely a registrar issue. The registrars not being able to find data because it was hard to understand that high of a percentage of physicians across the country, particularly in accredited programs, would be ignoring those same guidelines from accreditation. Was the registrar inaccurately assigning CTX? The CTX indicates no rectal assessment by exam or imaging, patient refused, or the physician didn't order. The exam or imaging results cannot be quantified. And again, the same issues. The registrar did not have access to the information, and that's not CTX. CTX may not represent what the physician knew about the patient. Some registrars incorrectly use CTX if they can't find information or don't ask physicians. Registrar using X and not blank skews the data for physician researchers. Registrar X could lead to incorrect conclusions and on patient care and actually jeopardize maybe some accreditation status of some of these programs. So I hope that really helps you understand that there is some harm when registrars are trying to decide between blank or X. And to kind of help maybe even more, here's an example from past registrar data collection issues. Maybe this will also help put it into perspective. So from 1998 to 2011, the registry definition written by registrars of a sentinel node procedure was, for sentinel nodes, all of them must contain dye or tracer. The sentinel node and the regional nodes would be coded. Both the sentinel node and regional nodes would be coded if any node did not contain that dye or tracer. So that was the registrar definition that was written without any physician input. Well, I remember I was in the hospital during some of this time, and that was not the definition my physicians were giving. And I know I asked my region, my state, NCDB, a lot of different groups, are you sure this is the definition? And they said, yes, this is the definition. Well, in 2011, an analysis was done of the NCDB breast data. They found 28 to 29% of patients undergoing axillary dissection did not have a preceding sentinel node biopsy, which was not standard of care at that time. And also, breast patients with negative sentinel nodes were going on to have full axillary dissections. That was also not standard of care. Well, the data was presented at a national physician conference. They talked about this potential evidence of inappropriate patient care by physicians across the United States. And the physicians in attendance at that national meeting stood up and questioned the findings. They said it just didn't sound right. Then the validity of the data was called into question by 3 separate groups who happened to be also around that same time analyzing the data that had come in and said it just didn't match with what physicians were saying they were doing. So then in March of 2012, a letter was sent from NCDB. It acknowledged those registrar written definitions were incorrect. They were wrong definitions of what a sentinel lymph node is. They were also, registrars were wrongly told to code this from a pathology report. And they were also wrongly told to code as an axillary dissection if non-sentinel nodes were also removed. So the remedy that was provided in this letter is changes in the coding instructions. The physicians got involved and sat down and helped the registrars write appropriate coding instructions according to medical practice, how they do sentinel nodes and what they mean. Registrars were instructed to review operative reports in order to code information about sentinel lymph nodes. And registrars were instructed that nodes without dye or tracer are called non-sentinel nodes, but they are part of the sentinel node procedure. It is not an axillary dissection when you have a few nodes without die or tracer. So we had 14 years of inaccurate data, and hopefully everyone, physicians and registrars, can learn from this and prevent future mistakes. We must consult with physicians actively involved in patient care when data items and rules and instructions are being written to make sure that what the registrars write actually follows appropriate medical care and how physicians truly care for their patients. This is the only way for registry data to help physicians improve patient care and outcomes by truly reflecting what the physicians are doing and how they are caring for patients. So hopefully we learn from this and we don't continue making mistakes for years before stepping up and acknowledging that maybe we weren't doing it right before and we need to improve and do it right, because we do this job to improve patient care and outcomes. And if our data can't be used for that, then we have to really reconsider what we're doing. Physician data interpretation of X. The managing physician did not perform exam or imaging. The managing physician ordered tests, but the results were not clear. And that meets the AJCC definition of TX and NX. And we just saw examples from physician data questions about appropriate workup. You know, in the breast case, where breast exams or imaging not being performed. In melanoma, was no nodal area assessment being done? And for the rectal cases, was there no imaging assessment being done? That's what the X means. Now, the physician data interpretation of blank, the registrar did not have access to the information, so they had to just skip over that data item. They couldn't complete it. They couldn't fill it in with any type of valid AJCC category. Now, the registrar use of X and blank. For the registrars, assign X when it is clear that the managing physician does not know, they don't have the information. When the managing physician has not or could not assess the primary tumor or nodes, or the managing physician has assessed, but the results did not provide definitive information. So even if the managing physician doesn't say TX or NX, if it is clear from what they documented that they don't know, they don't have that information, or they did not or could not assess, then the registrar can assign X. You know, you don't always have to find exactly that letter written in exactly that way. Registrars have enough knowledge and information to be able to read the physician documentation and perform that critical thinking and understand what it means. Now, registrars should leave the category blank when registrars do not have the information. There is no evidence the managing physician did not assess the patient, or the physicians were using uncertainty rules with main categories. For example, if there's only a T3 or a T4 and there's no subcategories, and the physician says this is either a T3 or a T4, well, registrars are not allowed to downstage or use the lower category. Registrars can't use X because that's not what the physician said. So the only thing you have left to do is to leave it blank, skip over it, don't fill it in, because you do not have the necessary information to assign that category. Registrars must prioritize accuracy over completeness. Registrars must leave data items blank if the necessary information is not available. You can't get around this. You can't fill in every data item with some type of meaningful code. I know we don't like to skip over and not fill in a data item, but that's what you have to do. Because when you try to fill it in with an X and it's not appropriate, it skews the data. It causes this misinterpretation by the physicians and the researcher and just confounds all of the data. We have to prioritize accuracy over completeness. So understanding the significant difference, blank versus X. So the correct use of blank or X. This is causing data analysis issues and misinterpretation by physicians and researchers. It has to be that the tumor cannot be assessed and only the managing physician assesses the cancer. Blank makes more sense. It's usually more accurate. I really don't understand the registrar reluctance to use a blank. There is potential harm coming from the use of an X. So why not leave it blank? Registrars do not assess patients, and therefore registrars cannot make the call to assign X. We really need to refine and reinforce the instructions for clear data. And it makes a difference to the physicians who are using the data, and that's what's critically important. If it makes a difference when the physicians are trying to assess the data to improve patient care, we have to be accurate. The guiding principle, always tell the patient story from the managing physician's perspective. So that's the issue for blank versus X. I like to talk a little bit about the risks and benefits. So let's look at X first. Look at all the risks. Is the patient confident the physician did not know? It may not accurately represent the physician information. It may lead to misinterpretation of data if the physician did know. And there's no advantage to using X instead of blank. The benefits. It clearly conveys the physician did not know, if that is accurate. Now let's look at blank. We see a total flip-flop on risk versus benefits. There's only one risk, and that really is none. There is no risk. If you leave a data item blank, the T or the X, T or the N blank, there is no risk. No information is lost at all. The benefits of leaving it blank. The registrar is not penalized for blanks. Using blank instead of X does not lose any information. There is no advantage to using X instead of blank. It's better to err on the side of caution by using blank. And it's best if you're not sure if the physician does not know to use a blank, because you can only use an X if you know for sure. So looking at this, the risks and the benefits, the blank clearly wins in risks versus benefits. Blank versus X, the solution. The solution is clear from the data evidence and the benefits versus risk table we just saw. It is critical for registrars to assign T, N, and M according to the definitions in the AJCC staging system. When necessary information is not available, registrars cannot assign TX and NX. Registrars must leave the data items blank. There is no other valid AJCC T&M category that can be assigned. Registrars must discriminate between blank and X usage. Assign X only according to AJCC rules. Protect the accuracy and the integrity of the data. Registrars must value accuracy over completeness. I know registrars like to be able to fill in every single data item. It's like going through and filling in one of those answer sheets where you color in every little bubble, and you don't want to leave one of those empty or blank or skip over it. But that's what you have to do sometimes, because accuracy in this case is so much more important than completeness. Information and questions on AJCC staging. Timing is everything. This graphic is available for a free download from the AJCC website. It defines the time frame in arrows and the criteria in the square boxes to help registrars get a visual picture of how and when to use clinical, pathological, or post-therapy staging and what information is included. The AJCC website is cancerstaging.org. It includes general information as well as version 9 and 8th edition. And there is the AJCC 8th edition, Chapter 1, Principles of Cancer Staging for a free download if you need easy access to this, along with cancer staging education and frequently asked questions and resources. Cancer Forum is a great place to submit questions or to review questions that have already been submitted to learn from them. This provides information for everyone. One person submits a question and a lot of people can learn from it. So always search first to see if your question's already been asked. It also allows us to track for educational purposes and to help us choose what education needs to be done based on the types of questions being asked. This was developed through generous support from the American Cancer Society, and we thank them. And I'm Donna Gress, and thank you for your attendance.